And then Jason, speaking of frontline targeted therapy, I guess we now have longer term data that'll be presented at this ASCO. I think it's an oral presentation from Nathan. So what can you tell us about that abstract? What does it say?
Yeah, so these are the 4 to 5 year follow-up on dabrafenib trametinib phase 3 clinical trials, and I think the data actually are pretty impressive, and I think it's really worth highlighting them, although they have to be put in context. I always like the term that you often throw out about the urban legend that all patients who get targeted therapy eventually progress, and I think what we can really definitively say based on this abstract is that that's not true. So at 4 and 5 years, we saw that the progression-free survival was around 20%. So that means that about a fifth of the patients never progressed on targeted therapy. And I think that's really important, right? So that really is a change from the way people have commonly thought of that. And the overall survival for those patients sort of in the mid-30s, and that's pretty good as well, considering the historical experience in melanoma. I think another really important aspect of this to sort of note is sort of the stratification within this analysis, which is to say that the patients who had a low LDH, which is a blood biomarker that we use in melanoma, that strongly stratified the outcomes of the patients. So that at 4 to 5 years, the patients with low LDH had a 40% progression-free relative to those with high LDH, less than 10.
So a 50-year-old marker now still
exactly.
is one of the most important prognostic factors in melanoma. Well, how far we've come.
Yeah.
Interesting.
And yet most people say, give BRAF/MEK to the high LDH patient because they've got the highest
Which
tumor
is
burden.
an
We have
absolute contradiction when you think about it.
Think about it.
Yeah, an argument could be made if we just had a biomarker to identify who those 40% of patients would be, we would know which patients we should be offering, other than LDH. Obviously, LDH identifies the 40% that are going to be progression-free for a while. But if you had something to just say, I don't have to worry about immunotherapy yet for this person, I can just give targeted therapy, it would be really useful.
Well, one thought is that you should combine these, and in fact, I think Georgina Long has an abstract, Hussein, at this meeting where there'll be preliminary data from the Combi-I study, which again is spartalizumab dab-trem. So what can you tell us about that?
Yeah, so on the surface, it sounds like since we have so much frustration deciding whether targeted or immunotherapy, why not give them all, right? This is kind of the approach. But the reality is this is really heavily based on some really compelling translational data that shows that BRAF-targeted therapy actually improves potentially the outcome of immunotherapy by making the tumor microenvironment more favorable for immunotherapy and for T cells to infiltrate, for T cells to actually kill tumors as well. And so based on those data, there's been several trials that have combined BRAF-targeted therapy with PD-1 antibodies that have shown some promising efficacy, and that approach is now in phase 3 testing. And Combi-I is essentially a phase 3 trial that is designed to test the question of whether spartalizumab, an anti-PD-1 antibody, combined with dabrafenib and trametinib, can actually be more effective in the first-line setting for BRAF mutant patients versus dabrafenib and trametinib alone. Now, that study was designed in a way that had actually 3 parts. The phase 3 that I just discussed was part 3, but part 1 and part 2 were actually designed. Part 1 to determine the safety and make sure that those 3 drugs can be given at full doses in this population, which it did meet the primary endpoint, and that's how that evolved to part 2 and part 3. And part 2 was actually a 27-patient study that was a translational study with biomarkers. The patients had to have biopsyable disease and had biopsies before and after. So what is being presented at this meeting is actually some safety and efficacy data from those 2 parts. It was 36 patients, so actually a sizable population in terms of looking at that question, specifically the safety, and it was clear that the triplet combination has a higher rate of toxicity. There is no question about that. However, when you actually do some dose interruptions, dose reductions, and kind of follow some algorithms that have been developed as part of this study, actually you can still deliver the 3 drugs together. And so about 17% of patients discontinued all 3 drugs, but again, that means the other 83% managed to get them. Interestingly, from an efficacy perspective, there was an overall response rate of 75%, and 33% were complete responses, which is higher than what you would expect from dabrafenib and trametinib alone. So it's really intriguing data, and I think it gets us even more excited about seeing what the triplet therapies are going to do in the phase 3 trials.